Hello and welcome to the latest Investec Focus talk, a series of candid discussions with leaders, innovators and change makers. I'm Max Richardson, Senior Investment Director at Investec in London, and I'm delighted to be joined by Tim Spector, genetic epidemiologist, author, and most recently the driving force behind the Zoe Covid Symptom Study, arguably the most comprehensive and reliable data set on COVID-19 in the UK, and one of the largest public health studies in the world, with nearly 4.5 million participants. Tim, welcome.
Hello there.
So much really interesting ground to cover today, but before we start, we'd like to hear a bit more about you. We've known each other for many years because you trained at the same medical school as my parents. I think I'm right in saying that we're both retired windsurfers and ski tourers, a subject I want to come on to a bit later. But I thought it'd be great for our audience to hear about your background and journey to this point, where you find yourself the lead of one of the largest public health studies ever undertaken.
Yeah, well, that journey could take us several hours, but I'll try and cut it short. To say that I was looking forward to a nice, quiet summer when COVID basically closed down my twin research unit, which is what I've been doing for the last 25 years. I've dabbled as a consultant in medicine and rheumatology. I always liked epidemiology and then got into studying twins in a big way. And that's really where I made my mark. And so we have these 14,000 twins that we've been looking at for the last 25 years. And basically we were told in about mid-March that everything was going to close down and we'd have to stop all our studies. And we'd been doing these studies on personalized nutrition in the twins, working with this company, this biotech data company called ZOE, who are just around the corner from us in London. And it all seemed gloom and doom. And I just said, okay, well, I'll go and write some more books over summer. And unfortunately, on the cycle home, I got the idea of actually doing something in the twins that would link it all with COVID. So we'd find out in real time, were they getting infected or were they being protected? Was it their genes or their upbringing that was important? And so I phoned up the CEO of Zoe, Jonathan Wolfe, and immediately he said, that sounds fascinating. You know, we'll stop everything we're doing and try and repurpose our nutrition app for COVID. And 4 days later, amazingly, they'd come up with this app, and in a way, the rest is history. We had 1 million downloads in 24 hours and 2 million in 2 weeks, and now over nearly 4.5 million. And we're also in the US and in Sweden. So, and my life has never been busier. So I never got to have much holiday over the summer. So part of me regrets that, but it also, you know, I think we've done some amazing good. So the whole team feels quite proud of everything we've done so far.
And so you should. And I should congratulate you, of course, for your OBE, which you received a couple of weeks ago or so ago for this work. A couple of things to touch on there. First of all, your books. I mean, I want to talk about your latest book, Spoon-Fed, a bit later on, because actually there's an angle here which is very relevant to this conversation. But since we're talking about the app, perhaps you could just highlight very briefly the difference between the COVID Symptom Study app and the NHS app.
Well, we got ours out about 5 months faster than they did. That was the one important difference I think we're quite proud of. The other is that there isn't a research tool. It's purely to track and trace. And so their idea, it's all linked with Bluetooth technology, and you switch it on and it will record who you're coming into contact with, your locations, and through various algorithms try and pinpoint whether you need to isolate and have a test or not. That's really all it does. Whereas ours is much more multi-purpose. It doesn't track anybody. So the closest we get is your postcode if you want to put it all in. Everything else is voluntary and self-reported. And ours is much more of an interactive tool. So the government still only asks about 3 symptoms of COVID, whereas we ask about 25. And we know that they're all important at different ages and are also key to sorting out your risk profiles. So that they're very, very different animals. And every day we tell people what's happening in their area. We're giving them trend charts to see whether levels are going up or down. We give them questionnaires about diet or blood group or risk factors of disease, whatever's scientifically on the top of the agenda. And it's a fast-moving, fun piece of work. And the amazing thing is we've still got so many million people after 6 months who are still using it most days. And so I think it's quite revolutionary in how people are interacting, feeling comfortable giving their medical and personal information to a company in return for information back. And this is perhaps, the future of health in some way.
I mean, it's hard to overstate the power of the data set that you're building. And with that data, you were the first to identify things like the fact that loss of smell is a symptom in many cases of patients with COVID, that children present differently to adults, that delirium is a key sign in older patients. And then on a sort of hotspot basis, you were able to identify that Leicester was a potential hotspot before the government was. How does it differ in terms of the output to the government's published data? Because what we're talking about here is predicted outcomes rather than backward-looking published data, such as the ONS is reporting.
Yeah, so one of the features of the app is to provide data on incidence, number of new cases per day, and also prevalence rate. So how many people we think are currently symptomatic are in the country at the moment. And we provide daily updates on that. And what we've done, we started off back in March, there were no testing. So only a tiny fraction of people actually had any tests. So we used an algorithm to predict who was affected or not. And we published that algorithm, and it's about 80% accurate. And certain bits of it, like loss of smell, are virtually the same as having a PCR test. They're so good. So you don't necessarily need a test, which isn't itself perfect either. But our data now are based on a subsample of the population that we send invitations to every day to get a swab test. So these are anyone who's symptomatic on the app will automatically get an invitation by email saying, go to a test center, use this code, or get a test kit sent to you. And those people then report back to us a couple of days later, whether they're positive or negative. And then we extrapolate to the population by looking at the age and geographical stratas. And that allows us to give what seems to be a pretty accurate estimate of the real number of cases. So for the latest data, there's nothing can beat ours at the moment, although the government, because they're spending £12 billion on this system, has more resources than we do. Ours costs about 2 million. It is going to eventually perhaps overwhelm ours for size. But what it doesn't do is have a systematic way of doing it, and it doesn't report fast. So that's where I think we have the edge, and feeding back the information to individuals is also the other area where we're ahead of the game.
So, presumably part of the edge is, as well as the AI and machine learning that you use to build the algorithms, because it strikes me as being enormously powerful if you can predict either individual risk or areas that are likely to see most patients, because that has an impact then on the allocation of scarce resources.
Yeah, so we were at our most useful, I think, early in the epidemic when we picked up areas like South Wales and Liverpool and to a lesser extent Cheltenham. alerted those authorities too, when there was basically they had to wait for hospital activity before they knew there was something going on, because there was no other way of tracking the pandemic. Now, I think there's many routes of predicting hospital cases, and the government, are using the number of tests of people over 60. So I think our main use is more, I think, in the population at the moment, and the ability to use algorithms to see what symptoms people have in their first week predicts who's likely, as an individual, to need help, who's likely to need hospitalization, and who's likely to get long COVID. So I think, we're constantly looking at where our strengths and weaknesses are, and I think that's these algorithms and using AI in the first week, either to triage for people for hospital services or intervention trials. That's probably where we are, as well as helping with the vaccines.
We talk about immunity because there's some distinctions to be made, I think, when it comes to immunity between antibody immunity, memory T-cell immunity. There's a lot of discussion and debate as to what the threshold for herd immunity might be with COVID-19. And of course, we're seeing very, very low reinfection rates.
So when you get an infection like COVID, your body reacts in two ways, with what's called the innate system, which is something we're all born with, and is very often quite genetic, and allows us to have these T cells which already can pick up the virus and isolate it and stop it spreading. And the other form of immunity, which is involves memory cells and producing antibodies, that takes a bit longer, but then can produce maybe longer lasting immunity. And what's clear is that you're getting both sorts in this infection. So you're getting both sorts of the infection of this immune response. And you can't, at the moment, measure T-cell response well in the population. So we're guessing what's happening in the population. They've done it on a few people. It's extremely expensive, whereas you can measure antibodies in millions of people. And we know that most people produce antibodies who have a severe infection, but it disappears in half of them by about 3 months. And we don't know how long they last particularly. So there could be several ways you're resistant to the virus, both T cells and B cells. And that complicates the whole thing. It complicates vaccines. And but it could be the reason that a lot of people have been exposed to the virus, don't get ill. It's not because they already had these B cell antibodies, but actually they had a really tough innate T cell system. And even if their partner was coughing all over them, like my wife, when I had it, she didn't get ill. And so there's many cases like that. So I think we've got to we can't guess what's going to happen based on the immunology. We've got to wait and see what the data show. So far, from our several million users, we've had only a handful of reports of reinfection, and they can't be validated because you don't know that they didn't just have a relapse of some kind of long COVID at the moment until you did genetic testing. So, but I'm relatively confident that it is like what the risk is really, really small at the moment, within 6 months. And I think that should reassure people. And if that's true, that's going to have a very different type of implication for how long it lasts, and whether places like London that were affected very badly in the first wave are going to do better in the second wave if they've got, something at least like 40% of the population resistant to it.
So the drawback of all statistical studies is that the sample isn't necessarily representative of the population. Now, you clearly have a very large sample, 4.5 million people, but it'd be interesting to know how many of those people are updating on a daily basis, as opposed to people like me who updated when I felt ill, but then stopped updating. So can you give us some comfort that the people who use the app are representative of the population at large? Or could there be a skew to some degree in the data because it's mainly people who feel ill that are using it?
Well, to answer the first question, we have about 1.5 million people who fill it in on most days, and they look at their results. And people like you who, stopped filling it in, we're trying to get you back so we can see if you get a relapse, and we can look at that. And we're adding features about your local area to make you interested to look in anyway, just to get facts about the pandemic you can't get anywhere else. We think it's representative of working age people who own a smartphone. And but obviously we're not getting as many ethnic minorities, we're not getting deprived neighborhoods, we're getting less people aged over 80 who can't use a smartphone. Number of things like this, inevitably we get some bias. We perhaps get some bias in personality of people who can never be bothered to fill in any form at all. But largely what's nice is our data do mirror what's happening with the systematic ONS survey, where they pay people to have swabs stuck up their nose every week. And so that's reassuring, I think, for us. So we've not found major differences for most of the things we're looking at. But we've got to bear in mind that all surveys have this bias. Unless you work in a dictatorship, you can't force people to give you their data.
I think that you mentioned long COVID earlier on, which is something I want to come back to, because there's a big debate going on at the moment, and the Economist ran an article on this between those on the side of the so-called Great Barrington Declaration, who believe that we should let the virus run free among the younger population and protect the more vulnerable, and those on the so-called side of the John Snow Memorandum who think that's a very bad idea because it still means, even if in percentage terms the number of people that contract COVID and die is small, in absolute terms that's still many, many people. One of the things that's perhaps missing from that debate and is relevant to the outcome of your research, I think, is that even among young people, the phenomenon known as long COVID is something that should be borne in mind.
Yeah, so because we have this unique prospective cohort that people, in a way, enter the data not knowing what's going to become of them, we get a fairly unbiased look at the length of symptoms and what happens. And so from that, we found out that about 13% of people are still reporting the same symptoms at 1 month, and about 5% at 2 months, and about 2.5% at 3 months. So depending on where you think it's, the cutoff is, and that hasn't been defined yet, but to my mind, 3 months is a long time to be off work. It's a long time to have fatigue and brain fog, plus potential other neurological problems and loss of smell and taste and feeling terrible. I think that's when you start getting a real burden on society. And if you think about that, 1 in 45 people with that problem, that goes across all ages. It is twice as common in a 60-year-old as in a 30-year-old. So it may be in a 30-year-old, it's only 1 in 100, but that's still a lot of people when you think that there are millions of people who are getting this virus. So there could well be hundreds of thousands of people who do have at least 3 months of illness, and potentially, we don't know, it could be several years in a minority of those. So that's the restraining thing on, let's say, let it rip amongst young people. I should say that under 18s, doesn't seem to be very much risk at all, but it's that younger, the age group, including yourself, Max, that will still suffer. You're not going to die, but you might have longer term symptoms. And these are people that are crucial for the economy because they're, paying taxes, etc. So that has to be balanced against the downside, which is that by locking down people, you're going to get more mental illness, more depression, more cancers, more heart disease. And at the moment, my view on the Great Barrington debate is that yes, more people are going to die through the restrictions than will be saved from them than if we took something like the Swedish model, where we just acted responsibly without having major lockdowns. You know, we still maintained the masks, the distancing, washing our hands, and avoiding large groups. That would mitigate a lot of the deaths. So it's a debate that no one really knows the answer to, but I think it is important to have it, because the Great Barrington movement only works if we are going to be immune to this for several years, not just several months. And that's at the moment a bit of a gamble. And so, you know, that's probably why most countries are treading somewhere between the two, and until it becomes clearer. And I think we've got to look at the whole picture plus the economy when we talk about this. And the problem is we just don't have enough hard data. And so both groups are somewhat guessing, and it's coming down often to politics rather than to science on that.
Yeah, I mean, it's refreshing to hear you discuss the economy, because I think one of the observations that people in the financial community have had is that it's quite rare to find people in science who think about the economy, or at least allow it to inform part of their sort of decision-making process. Just talking about the countries, and I promised that we wouldn't get political when we were talking before. What can we learn, or what have we learned from other countries? Where have the outcomes been perhaps less bad rather than better? And what could our government learn from those countries?
Well, it's still evolving. So, I mean, the caveat here is that the countries we thought were doing really well are now some of them are doing really badly. So everyone was looking at Israel early on as a model country that locked down early, saved their economy and health system, and now they're doing, one of the worst in that area of the world, because they let the economy go back too quickly, and they're suffering now. We've got countries like Austria that were doing, and Switzerland that were doing well and now doing badly. So I'm not sure anyone's really got it right. We seem to be doing much the same as France and Spain and Italy, our sort of near neighbours, and even Germany now, who are seen as the absolute model state, and they definitely were in the first wave. Nearly everything Germany did, we did the opposite, and we screwed up. So our centralized model of doing everything was complete rubbish. We had this rigid governmental idea, which I think I heard called as NIH syndrome, not invented here. We didn't want anything foreign, and we didn't want companies helping because they were just getting in the way. They didn't want local people to help. Local hospitals could have had testing up and running within a couple of weeks. They were told, like my hospital, not to bother. You'll just get in the way of these massive things that are going to succeed. So this mentality was wrong at the beginning. I think still partly wrong. These massive centralized projects like track and trace would be much better done at a local regional level. And that's what places like Germany that have more of a federalized system do seem to do better. And anyone else who tried to say anything different was seen as like a traitor rather than trying to help. And especially industry, there was so much red tape starting small companies helping that I knew personally. We had a company we worked with had a 20-minute test for PCR, and we wrote a paper on this in April, but it took 4 months of paperwork and bureaucracy slowing it down, and they could have been out there. And there's many other examples like that, because it wasn't a government tool. But anyway, we'll see. I think it's still too early to draw all the lessons. We're still learning them. So my view is, let's keep an open mind. I don't think anyone really knows what's going on here, if we're honest, and not have rigid views, and and collect as much data as we can.
One of the great fears was that, particularly in the developing world, that COVID would spread very, very quickly, and that because perhaps of the less developed healthcare infrastructure in many of the countries concerned, that the death rates would be higher. And actually, I don't think those greatest fears have necessarily come to fruition yet. And do you have any insight as to why that might be?
Well, epidemiologists were generally fearing, millions and millions of deaths across Asia, Latin America, and Africa, in the poorest parts of the world, with poor hygiene and poor health services. And the opposite has happened. So there have been some studies, for example, in favelas in Brazil, finding that about 80% of people have been infected, and yet hardly any of them had any major symptoms or went to hospital or suffered in any way. So, and when you look at the rates going across India, when you consider the sheer scale of the country, you should have seen 100 times more deaths than they were actually getting. And a similar picture across Africa, when we were discussing this with the WHO, and the countries couldn't quite work out why they weren't getting the deaths. People thought they were just hiding them, but it turns out not to be true. So affluent areas of the world are actually suffering much more than the poorer ones. And I think my explanation for this is that the immune systems of those people are very much more attuned to fighting off viruses every single day of their lives than our puny ones in the West, if you like, where we're over-sanitized, we use antibiotics too much, and our immunity is really pretty poor. And this is reflected also in our gut microbes. So in general, areas in Africa and India, they will have perhaps double the number of species of gut microbes that we have, which gives them better immunity.